It's a great pleasure to be here, and I'm very honoured to be the recipient and to be the Queensland recipient of the Sidney Sax Award for 2013. I certainly appreciate the personal recognition, but more than that, I appreciate the acknowledgement of the importance of women's reproductive health, and more specifically the recognition of the needs of Australian women for safe and accessible abortion services. I'm also aware that nothing positive ever comes about from the efforts of just one individual, and I would like to acknowledge the many, many women and men who have worked with me on the campaigns of recent years. I must admit that I didn't know a lot about Sidney Sax when I first heard about this award, but I have looked into his CV and it's impressive. He came from South Africa in the 1960s, and he had a long and productive life here in Australia. He made an enormous contribution to public health. He began as a clinician, as a geriatrician, and he was always a strong advocate of aged care assessment teams long before they became the norm. And this interest developed into the planning and provision of accessible, high-quality healthcare for the whole community. And he was the first to set up databases collecting information about health services and mortality and morbidity that allowed basic health service planning to be undertaken, first of all in New South Wales and then nationally. And this was really quite a novel idea in the 1970s when he began to do this. He played a key role in the development of Medibank, which was the precursor of Medicare. He was a strong supporter of research and innovation in healthcare, and it's fitting that he was a life member of the PHAA and is remembered annually in this award. I also think he probably knew a thing or two about advocacy in challenging environments. This is what I've been asked to talk about this evening, and when I saw this topic I thought, what am I going to do? Go along and talk to the PHAA about advocacy? It's like teaching my grandmother to suck eggs. The PHAA has a long and proud history of advocacy in such areas, challenging areas, as Indigenous health, prisoner health, and tobacco and alcohol control. You were directly involved in the campaign to overturn the Harradine Amendment and allow mifepristone to be available to Australian women in 2005-2006. You've been vocal in calls for equitable healthcare for refugees and asylum seekers, regardless of their visa status. These are both areas where I have an interest and where I've been aware and appreciative of your contribution. However, I have given some thought to this question of advocacy in challenging environments, and I've thought about what is needed generally, and I think it comes down to two things: the facts and passion. First of all, the facts. One comes to an issue or an event with certain basic beliefs. For example, that women should have control of their own reproductive health. And this then extends to their right to decide about abortion when faced with an unplanned pregnancy, and to obtain that abortion safely and legally if that is the decision they make. On another matter, asylum seekers and refugees in Australia and those transported offshore are the responsibility of the Commonwealth Government. Therefore, Australia must be responsible for providing equitable healthcare for these people. But beyond those beliefs, which are based on principles of social justice and embedded in the concept of human rights for all, one needs one needs facts in order to convince an often powerful and disbelieving opposition. Advocacy, like medical practice, needs to be evidence-based. So here are some facts, which I hope might form the basis for our later discussion. 50% of all pregnancies in Australia, even in 2014, are unplanned. Nearly half of these, and a small number of wanted but subsequently complicated pregnancies, end in abortion, 25% of all pregnancies. So there are about 100,000 abortions nationally, we think, when surgical and medical termination of pregnancy are added together. But we don't know exactly how many there are because there is no national database. Despite all the efforts since the initial efforts of Sidney Sax, we don't collect figures for abortion the way we do for every other health procedure. There are 9 different legal situations in 9 different jurisdictions in Australia with regard to abortion: the states, the territories and the Commonwealth. These range from complete decriminalisation in the ACT and virtual decriminalisation in Victoria and Tasmania, to the archaic wording of the criminal code, which is here now in Queensland. And the differing legal situations make abortion a crime for women in many regions of the country still. And though case law has to a large extent made abortion more accessible to Australian women, it still is a problem for doctors. There's an enormous stigma attached to abortion still in Australia. Many doctors are afraid to practice abortion or be involved, even though they want to be able to refer women requesting abortion to safe, accessible legal services. It also makes abortion less accessible to women in rural and remote areas and from certain ethnic groups. So the bottom line is that abortion is an important healthcare for Australian women. There's an urgent need for reform of There's an urgent need for reform of abortion law and for uniformity across Australia. There's also a need for a comprehensive national database so that we know exactly how many abortions are performed and why, and other relevant information about women seeking abortion, both from the point of view of adequate and accessible service provision and that of attempting to decrease the incidence of unplanned pregnancy. On another topic, there are currently 983 children in detention in Australian asylum seeker detention facilities. There are 196 children on Christmas Island, including 70 under the age of 1. There are 208 children on Nauru, including 10 unaccompanied minors. They will never be resettled in Australia, according to the current government, even if they're found to be refugees. There would appear to be plans for women to give birth on Nauru being hatched at the moment. Australia is the only refugee convention signatory to have a policy of mandatory indefinite detention for asylum seekers. Living conditions on Nauru are primitive. People are living in tents, they're hot, humid, overcrowded. There are difficulties. It's a very small island. I have been there working with AusAid some years ago. They are living in tents. There are problems with rubbish and sewage disposal, which mean that the risks of communicable diseases are very high. Christmas Island is not much better. Pregnant women are detained on Nauru. Obstetric facilities are very limited, and maternal and perinatal mortality figures for Nauru itself are 35 times those of Australia. Transportation to hospital care in Australia takes 36 to 48 hours to arrange and undertake. Far too long for children and pregnant women. Schooling is very limited on Nauru and on Christmas Island. Most of all, there are serious concerns about the mental health of asylum seekers. Documented in peer-reviewed journal articles, many of them have appeared in the Medical Journal of Australia. There are high rates of self-harm, high rates of presentation to emergency departments in near to mainland centres with symptoms of depression. I'm personally acquainted with a 16-year-old unaccompanied minor from a Middle Eastern country. He's been in a mainland detention centre now for more than a year. He has relatives in the community. He has an Australian family who wish to become his foster family. The Department of Immigration has said that this is not culturally appropriate. He remains in detention several days a week. Serco guards take him for counselling because he is depressed. Of course he's depressed in these circumstances. No amount of counselling is going to change this. So the bottom line here is that mandatory detention of asylum seekers, quite apart from the ethical and moral aspects, it's very bad for health, and asylum seekers should not be indefinitely incarcerated like this. In fact, they should not be detained except for a very short time for initial processing. Now, the second thing needed for successful advocacy is passion, which translates, I guess, into commitment and motivation. You need to be in it for the long haul. There are two phrases which have always stayed in my mind since my youthful activism in the late 60s. One is to maintain the rage, in the words of Gough Whitlam. I can see I'm dating myself here. The other one is from Bob Dylan. If you're not part of the solution, you're part of the problem, and I've always believed that. However, a lot of the work of advocacy is boring or mundane. I've been asked by Peter to say a bit about my own experience of advocacy. So I'll just tell you a little bit about the initial stages of the A486 campaign. It was in 2005 that I went to the annual scientific meeting of the American College of Obstetricians and Gynaecologists in San Francisco, and that's where I really began to realise the benefits that medical abortion could have for Australian women. And I came back to Australia and I tried lobbying my own college and I didn't get anywhere. So I made a more systematic plan. First of all, I would inform practitioners of the benefits and details of medical abortion. The second was to inform politicians. And the third was to try to get approval to use the drug myself. So I wrote an article about medical abortion, which the Medical Journal of Australia kindly published. And then I wrote personal letters to every single state and federal politician in Australia, which took quite a while. But at that point I discovered that there were a number of federal politicians right across the spectrum, the political spectrum, who were also keen to see the drug available. And we began to liaise and work, and so did many, many other people. I know the PHAA was very much involved in this campaign. The initial problem was Senator Harradine, there he is, whose Harradine amendment had required the import and use of RU486 to be personally approved by the Health Minister, who at that time was, of course, Tony Abbott. So it was very difficult. But the private member's bill, which was subsequently brought by the 4 women senators right across the spectrum, and our own Senator Claire Moore, still in the Senate on the extreme left there, was successful, first of all, in the Senate and then in the House of Representatives at overturning the Harradine Amendment. There was still a lot of controversy around the drug, and no drug company wanted to be associated with it, and they didn't want to apply to the TGA to distribute it. So with my colleague in Cairns, Dr. Mike Corrett, I began an application to the TGA using a loophole in the legislation, the authorised prescriber legislation, that allows doctors to import and use drugs which are unavailable here but available overseas in their own practice. There was a humongous amount of paperwork to do, and I needed approval from my hospital ethics committee. Queensland Health opposed the application to the ethics committee, but there were people on that committee who were very supportive, and without Queensland Health knowing, they passed the application, and we sent it off to Canberra before Queensland Health really heard anything about it. There were also people, moles in the TGA, who rang me mysteriously after hours and gave me tips on how to negotiate the TGA. To our great surprise, we were approved after just 6 months. And this is the first mifepristone which arrived in Cairns in 2006. We were so surprised that we didn't know what we'd done with the protocols which we'd had to produce for the TGA. We had to run around and find them and work out what we're going to do with this drug now. And we were very anxious when we first began to use it, because we were the only doctors who were able to do it for a couple of years. And we used to give our mobile numbers to the women we were treating and tell them not to fail to call us and reassure us that everything was going well. But then after 2 years, more doctors were approved by the TGA, and finally the Murray Stokes group, together with help, I think, from the PHAA, applied for and have been given national marketing rights, and the drug is increasingly, although not completely, available to Australian women. The point of this story, though, is that at the start of any campaign, I think that there's a lot of quite boring work to inform people of the facts about what you're advocating. And generally, to bring about change, you need a long time, sometimes years of relentless and sometimes apparently unrewarding work. And I think that these aspects of advocacy can be seen in the work of Sidney Sax. He carefully collected the facts, and then he acted with passion and commitment. For most of us here, the challenges involved in trying to bring about good are not likely to include personal danger or life imprisonment. I, for one, would be very uncertain of my ability to sustain advocacy in the face of such circumstances. But there are some whose commitment and passion are several degrees of magnitude above the ordinary, and who therefore can inspire us to greater efforts. And I would just like to acknowledge one of these. This is Private Bradley Manning, a former United States intelligence analyst, now known as Chelsea Manning. A few weeks ago, at the time of the renewed violence in Iraq, I read on the website of the New York Times an opinion piece by Chelsea Manning, this is Chelsea, on the role of the media in manipulating the views of the American public in regard to the war. And my first thought was, but Chelsea Manning's in prison for a very long time. Yet somehow, she's still writing, she's still getting her message out. As Bradley Manning, Chelsea was sent to Iraq, where she soon saw many things that appalled her. As an intelligence analyst, she had access to a huge amount of US security information and videos that over a period of time were copied by her and forwarded to WikiLeaks. This story is now well known. They formed the main part of the first major leak from WikiLeaks, and they included videos of the airstrike in Baghdad in 2007 that killed a family mistakenly targeted by a US helicopter. They included 250,000 US diplomatic cables and 500,000 US Army reports that together compose the Iraq and Afghan war logs. All this material Manning copied secretly and at great personal risk. Very tedious work, I would think. Much has been written about Manning's troubled early life and her uncertainty about her gender identity. But there's no doubt that her motivation in copying and releasing the information was directly related to her overwhelming opposition to the war and her desire to tell ordinary people, especially Americans, what was happening. As she said of her own actions, if you had free rein over classified networks and you saw incredible things, awful things, things that belonged in the public domain and not on some server stored in a dark room in Washington, what would you do? Well, we know what Chelsea Manning did, and we know what happened. She was arrested in April 2010, and she waited 3 years to come to trial in US military prisons, the first year in extremely harsh conditions. She was found guilty on 20 charges last year, although not on the most serious charge, that of aiding the enemy. She's currently serving a very long sentence, which has been criticised by many Americans, including members of the government and the military. Yet in prison, she still finds a way to continue to speak out. Her opinion piece is lucid and well-informed. She knows what she's talking about. Here we see the facts, a very large number of facts, presented with a passion that burns even more brightly. Few of us will ever act as Chelsea Manning has done, but she can nevertheless inspire us all. So I hope that I've given you some material for discussion, and I thank you again for inviting me.